Good morning, and welcome to the Johns Hopkins briefing. Today's briefing will focus on the conclusion of the COVID federal public health emergency in the United States. My name is Lainey Rutko, and I'm the Vice Provost for Interdisciplinary Initiatives at Johns Hopkins University. I'm also a professor at the Bloomberg School of Public Health and the School of Advanced International Studies. I'll be moderating today's briefing. Since 2020, the COVID-19 pandemic has impacted nearly every aspect of our personal and professional lives. Now, as the federal government ends the legal declaration of emergency, it's an ideal moment to consider lessons learned and best practices. I am so pleased to be joined by several of my dear colleagues from the Johns Hopkins Coronavirus Resource Center today. Crystal Watson is a senior scholar at the Johns Hopkins Center for Health Security and an associate professor at the Johns Hopkins Bloomberg School of Public Health. Beth Blauer is associate vice provost for public sector innovation at Johns Hopkins and an associate professor of the practice at the Carey Business School. Bill Moss is executive director of the International Vaccine Access Center and a professor in the Johns Hopkins Bloomberg School of Public Health. And Brian Garibaldi is director of the Biocontainment Unit at Johns Hopkins Hospital and an associate professor at the School of Medicine. Before I turn to each of our panelists for their initial thoughts, I want to remind our audience that we will be providing answers to your questions today in real time. So please submit questions for our experts in the box that you see at the bottom of your screen. When you do so, if possible, please include your organizational affiliation. We'll start by having each of our panelists give a brief overview of key topics, and then we'll move to Q&A. Crystal, I'll turn to you first. Can you tell us about the current state of the pandemic? After 3 years, is the end in sight?
Thanks, Lainey. Yes and no. With the U.S. public health emergency expiring tomorrow, and in addition, last week, the Director General of the World Health Organization declared that COVID-19 was no longer a public health emergency of international concern, or a fake. I think we're seeing an end to a phase in the pandemic, but there are complications in this. So the end of the fake and the coinciding end of the public health emergency in the U.S. is coming at a time when we are seeing decreasing trends in COVID-19 deaths, a decline in hospitalizations and intensive care unit admissions for COVID, and high levels of population immunity to SARS-CoV-2. But this is not a declared end to the pandemic, and there's no real mechanism to declare an end to the pandemic, but it is an end to the emergency phase, both in the US and globally. Overall, we are seeing in the US that cases, hospitalizations, and deaths are trending down and remain relatively low compared to all other phases of the pandemic that we've experienced thus far. This is in the US, but also internationally. And of course, this is very positive and something that we want to see. But there are a few things to note with this. In the US, we are still seeing about 1,000 COVID deaths being reported to the US Centers for Disease Control and Prevention, the CDC, every week, which would still put COVID in or near the top 10 leading causes of death for the year if that rate continues. So this is still significant. The end of the public health emergency, both in the US and globally, also means that surveillance will further decrease from what we have been doing, and we'll have less visibility into trends for cases in particular, as well as hospitalizations and deaths. And we should also remember that SARS-CoV-2 has not yet settled into a seasonal pattern, and we're not sure if or when that will happen. We continue to see the rise of subvariants of the Omicron variant. And with those comes each time a surge in cases and some surge in hospitalizations and deaths. These surges have been relatively mild compared to prior phases of the pandemic. And this is largely due to the large amount of immunity that we've built up collectively. But the surges are still happening. CDC says that it will continue to conduct sequencing surveillance to look for new and potentially dangerous variants, but that surveillance will likely lessen, especially globally. So variants right now that we're tracking in the US, the XBB.1.5 variant continues to be the dominant one in the US, but 1.16 is growing from week to week. And this is from the latest CDC Nowcast. It made up approximately 13% of cases. So like I said, we're still seeing these surges over time, and I think that will continue. But overall, we're in a much better place than we were, say, a year ago. Thanks, Lainey.
Thanks so much, Crystal. Beth, turning to you, where do we stand in terms of COVID data collection at the federal, state, and local levels?
Yes, thank you, Lainey. Thanks for the opportunity to engage in this briefing and to continue this work with a stellar group of panelists. So I'll start with the good news. The good news is that the mark of the end of the emergency doesn't necessarily mean the total stoppage of data collection. In the CDC's most recent briefings on data collection, that was on behalf of the entire entity of HHS, there were three sort of highlights. The first one is that genomic sequencing that Dr. Watkins was referring to will continue. So we'll start to see, or we'll continue to see at least that sequencing in the short term. The second area where we'll see continued data collection is in hospitalizations. Hospitalization data has become very relevant. It also became one of the most reliable data sets as we saw a shift from a reliance on PCR testing to at-home testing. Hospitalizations emerge as a pretty critical dimension of our reporting, and that will continue. The second thing that we're going to see continue at the national level is also death reporting. And so death reporting has been optimized as a result of the COVID emergency, where we saw some approaches within the federal government to make that data better, to decrease lags in how that data is reported. And I think we're going to see a continuation of that work. The things we're not going to see, we're not going to see the community level tracking. So our county-based data is going to be going away, coinciding with the end of the emergency. As you know, here at the CRC, we also have discontinued our data collection efforts, largely because state and local governments have began to make a shift away from data collection. And so we made the difficult decision to stop our collection when we realized that we did not have that kind of flow of public data that had been coming out of state and county governments, and made it very difficult for us to be able to reliably provide that information. The CDC is also signaling that they too are not going to be collecting that data at the community level. So those community risk assessments are going to be going away at the end of the emergency. And so the data landscape is changing. And it's going to sort of eliminate our ability to get hyper-focused local data, so we can navigate some of those decisions that we were relying so heavily on data to help us understand how we would engage in public life. This also begs a larger question on the field of public data infrastructure in public health. And we're hoping that there continues to be learning from the COVID emergency on the state of public health data infrastructure. But right now, we're still deeply reliant on individually negotiated agreements between state and local governments and the CDC. So if states are collecting data and they're submitting that data, that is going to depend on what those agreements entail. And that includes some of the optimization around the death reporting. So there's still some open questions to see exactly the tenor of that data and how that data will evolve over time. But at the moment, we're going to see these more scaled up national looks at the data. Globally, we're also seeing the same effect happening, where we're seeing a slowdown of data being collected and being shared on public sites. And so we're sort of waited with bated breath to see the field. And as we see the continuation of COVID and the evolution of the disease itself, how much information we will actually have for contextualizing our own decision making.
Thanks so much, Beth. Bill, over to you. Do COVID vaccines remain accessible, and what are the current recommendations?
Yes, thank you, Lainey, and it's great to be with all of you again to mark this milestone at the end of the federal public health emergency. I think it's important to reflect on the remarkable progress that was made over the past 3 years in developing new vaccines against SARS-CoV-2, and really in conducting the largest global mass vaccination campaign ever, with more than 13 billion doses administered globally and more than 70% of the global population having received at least one dose of a COVID vaccine. However, it has become more complex and messier to evaluate vaccine effectiveness because of the changing variants that Crystal mentioned, and this hybrid immunity where people have immunity to SARS-CoV-2 based on both infections and different vaccination histories. But that said, the bivalent booster doses continue to provide protection against severe disease, particularly hospitalizations and deaths, with some studies estimating 9 times lower risk of dying in those who receive the bivalent booster compared to unvaccinated individuals, and a 2 times lower risk of dying compared to those who are vaccinated without a bivalent booster. The current recommendations, Lainey, on April 19th, the CDC recommended a second bivalent booster dose for adults 65 years of age and older, and for those with weakened immune systems older than 5 years of age. This second bivalent booster should be administered at least 4 months after the first booster in older adults, and at least 2 months after the prior booster dose in those who are immunocompromised. These new recommendations also came with recommendations that for those who are unvaccinated, they can receive just a single dose of the bivalent booster, and we're no longer will be using the monovalent vaccine here in the United States. What we expect going forward is that we anticipate that there will be recommendations for broader use of an additional booster dose for the general population coming up this fall. We expect that the composition of this booster dose will be decided in June of this year. It'll be very interesting to see what this looks like, whether it contains the original virus variant as the current bivalent vaccine does. And I imagine it'll contain one of the XBB variants, perhaps the 1.5 that Crystal mentioned. So we're obviously marking the end of the public health emergency, and this has some impact on vaccination going forward. So for example, vaccination against COVID-19 will no longer be required for non-US travelers entering the United States. But independent of this end of the public health emergency, the US government is going to stop purchasing vaccines from the vaccine manufacturers. They're purchasing at about $20 per dose. And both the Pfizer-BioNTech and the Moderna vaccines will be sold commercially. We expect this will be happening in the fall sometime. And we expect that the price of the vaccine will probably be on the order of 5 to 6 times what the US government is purchasing it. Now, for those who have private insurance, the vaccines will still be covered as required by the Affordable Care Act. Medicaid and Medicare will continue to, will also provide the vaccine for those who are covered by those programs. The US currently has a stockpile of COVID-19 vaccines on the order of about 100 million to maybe 120 million doses. Those will be used And particularly the concern is for the uninsured people here in the United States, on the order of about 30 million people. And the US government will use that stockpile to provide free vaccine, and is also aiming to invest another $1 billion to provide vaccines for uninsured. But I think the big concern, Lainey, is really about the low demand for vaccines. We haven't seen much of a demand for the current bivalent vaccine. Only about 17% of the eligible US population has been received that. Higher for older adults, maybe on the order of 40 to 50%, but still that's a big concern. Going forward, there have been 50 COVID vaccines approved, hundreds in development. Many of those probably won't see widespread use, certainly won't see widespread use. The US government is planning to invest $5 billion in what they call the Next Gen project to produce next generation vaccines. We certainly don't have the ideal vaccine. We have very good, very safe and effective vaccines, but not the ideal vaccine. We'd like to see vaccines that are more effective against variants, perhaps even a pan-coronavirus vaccine. We'd like to see more durable immunity and not the type of waning immunity that we're seeing with current vaccines. And our current vaccines don't prevent infection or block transmission well. So those are some of the goals for the ideal COVID vaccine. These aren't going to be easy to achieve, but I'm hopeful that that further investment by the U.S. government will spur new developments in vaccine technology that may have spin-offs with other vaccines. And these might include nasal vaccines or delivery of vaccines through microarray patches. So just to summarize, kind of what is the legacy of our experience with COVID-19 vaccine at this kind of milestone, the end of the public health emergency? As I said, we've seen real development in new vaccine technologies. We've seen a massive global mass vaccination campaign. We've seen interest and investment stimulated in regional vaccine manufacturing to address some of the global inequities we saw. But I think we also there are also some negatives. The pandemic has led to real polarization and kind of hardened anti-vaccine sentiment, anti-science beliefs and communities, and those are going to continue to be a challenge to really maximize on the benefits, the public health benefits of vaccines. Thank you, Lainey.
Thanks so much, Bill. Brian, finally to you. What are you seeing these days in the hospital? And can you tell us what we've learned so far about so-called long COVID?
Well, thanks, Lainey, for having me back, and it's a pleasure to see everyone again. Thankfully, right now, we're not seeing much in the way of COVID in the hospital. Just to put it in perspective, as of this morning, we had 15 COVID positive patients in our entire health system. And during some of our prior peaks in the winters of 2020, 2021, we had over 600 patients with COVID in the hospital. So patients are not getting hospitalized nearly at the same rate as they used to. And I think part of that is obviously due to the effectiveness of vaccines, prior immunity from prior infections, as well as successful outpatient therapies that can prevent the progression to severe disease and death. But in addition to seeing not many patients in the hospital in general, we're also seeing very few patients, if at all, in our intensive care units. As of this morning, we only had one intubated patient in our entire health system with COVID. And just from my own personal experience in our intensive care unit over the last 3 months, I've only seen a handful of patients who were in the ICU because of COVID. And so I think the progress that we've made in terms of being able to prevent severe disease and hospitalization, and then preventing ICU admission in those patients who do become sick enough to come into the hospital, is quite amazing. And again, it goes back to a combination of vaccine-mediated immunity, prior infection, but also the success of some of our treatments that we have for early on in COVID, but also for some of the inflammatory effects that people get on the way to severe COVID. Unfortunately, we have not seen much in the way of new knowledge or understanding about long COVID over the last little bit. There's been a lot of money that's been put towards research through the NIH and other organizations to try to understand long COVID. And we still don't have a clear understanding of why it happens to certain people, And more importantly, how can we treat it once it does happen? It's estimated right now that there are probably close to 65 million people worldwide who have long COVID. That's probably an underestimate. Obviously it's changed over time. The incidence of long COVID, or the risk of developing long COVID, is probably lower with newer variants than it was with the initial wild type strains. But by some estimates, between 10 and 20% of new cases of COVID can result in symptoms that persist for more than a month, and in severe cases more than 6 months. And this obviously has a huge impact on people's quality of life, but also has a huge impact on the public at large and the workforce. It's estimated that almost 3/4 of people don't get back to work at 6 months, and only 20% get back to work at a year, which has huge implications for how we deal with this moving forward as a society. What we have seen is that vaccines do decrease the incidence of long COVID. Patients who have used oral antiviral therapies, it seems like that reduces the risk of developing long COVID. There was even a recent study that came out that showed if patients were treated during their acute COVID infection with metformin, the likelihood of developing long COVID was reduced. What we don't know yet is will any of these treatments be effective in patients who already have long COVID? So there's ongoing studies that are going to be looking at using antiviral therapies to treat patients who already have long COVID, to see if perhaps there's a viral reservoir that will be knocked out by antiviral therapies and perhaps improve symptoms. We simply don't know that yet, but that's something that I think as we move out of the public health emergency, a lot of attention is going to be focused on trying to understand how we help patients who have already developed long COVID over the last 3.5 years.
Thanks, Brian. And before we move to Q&A, I do want to remind those who are watching, we are keeping an eye on your questions as they come in. We have all 4 of our core experts from the CRC here who are anxious to answer your questions today. I see them coming in. Please do continue to submit them over the course of this next half hour or so. Crystal, I'm going to send the first question to you, and this picks up on something that you mentioned in your opening remarks about additional variants that we're seeing now. What is the likelihood that we'll see an outbreak similar to what we've experienced in peaks and valleys over the last 3 years from one of these new variants?
Yeah, I think we can't say for certain what the likelihood is of the rise of another dangerous variant, but I think as we have seen over the past 6 months or more, the variants that we're seeing that are causing these smaller surges are related to the Omicron variant. And if that continues to happen, I think the likelihood of seeing a large surge, a more severe surge that would cause more hospitalizations and deaths is fairly low. But we can't count out that there might be the introduction of a more dangerous variant not associated with Omicron or of the Omicron lineage. And so I think that's why it's important that the CDC and other international organizations continue to monitor variant emergence and do sequencing to understand what's happening, because we need to be vigilant about that. Although I think the likelihood is lower for that to happen than it was a year or so ago when we were seeing lots of transmission and lots of opportunity for introduction of potential new variants.
Thanks, Crystal. And Beth, I want to give you a chance to pick up where Crystal left off. How confident or not confident are you feeling when you think about the state of global data collection relative to COVID in the case of an emergent variant? How well are we able to pick it up through surveillance?
I think, one of the promising signs here in the United States is the continuation of a build out of wastewater surveillance. And I think that will have an impact. I think it does create some disparity, particularly for rural communities that are reliant on septic or reliant on systems that are outside formal systems. So it will make it more difficult for us to really understand the kind of deep texture of an outbreak. I think that with the hospitalization data, it will help us understand the severity of some of the ongoing variant and changes and shifts in the disease. And I hope that we continue to double down on our capacity to collect hospitalization data so that we can be sure that we have good information that we can quickly dispatch to local leaders and to jurisdictions. Globally, I think it's going to be tougher. We had a lot of data that was flowing, that was open, where we were able to sort of at least understand what was headed our way based on surveillance efforts that were happening across regions across the globe. And it's unclear at this point what that looks like going forward. And I think that uncertainty is certainly what a lot of us who are focused on the capacity of public health data are focused on right now. And it's something that we'll be continuously monitoring. The WHO signaled in their own announcements that they are still thinking about what this infrastructure will look like. And so we're here as experts to try to help support that decision making, and hopefully we'll be able to have some frameworks and some continuation of surveillance data that will then flow and help us stay ahead of outbreaks, and also help us understand the intersection of what's being felt in communities and what's happening in the sequencing and in some of the other passive surveillance that we're able to do.
Thanks, Beth. Bill, something that you've done such a great job of reminding us about over the last 3 years is to think of vaccination status not just in the United States, but also globally, and especially in areas of the world that are under-resourced. If you take a step back and ask yourself, how have we done? What's your take, especially for under-resourced areas of the world?
Yes, it's a really important question, and it's something that I hope kind of stays on our radar and our agenda, because I think the lessons are mixed. I think the major global effort to provide vaccines to under-resourced areas was the partnership that led to COVAX, and they had some successes and I should say many successes in getting vaccines to low and middle income countries. But there are also many challenges that they faced, and they were not able to meet their target goals in terms of getting the proportion of people vaccinated against COVID that they had originally aimed for. Some of the challenges were outside of their ability to control. So, for example, there was a large reliance on vaccines manufactured in India, and when India faced their big COVID surge, they decided, and one could have some sympathy for this decision, not to export vaccines, and so the supply into COVAX was restricted. So I think, Lainey, what this has led to is a lot of, as I mentioned in my opening remarks, interest and investment in building regional capacity for vaccine manufacturing, so that parts of the world, say countries in the Africa region, are not solely dependent on outside vaccine manufacturers. That's a whole complex issue in itself related to vaccine manufacturing and regulatory procedures. But I think that's an important move forward, at least to be thinking about how we diversify vaccine manufacturing going forward.
Thanks, Bill. Brian, can you tell us about the changes that you've seen over the course of the pandemic in terms of telehealth, its usage, yours or your colleagues' comfort with it, and do you see it as something that's going to continue to be incorporated into clinical practice to the extent that we've seen it over the last several years?
Sure. So, at the beginning of the pandemic, when hospitals essentially shut down all outpatient clinics in March of 2020, we went here at Hopkins from having a few dozen telehealth visits a month to over 1 million in the next year, right? I mean, so the effort that went in, not just obviously here, but across health systems in the country to build telehealth capabilities to try to reach patients who weren't able to come into clinic was incredibly impressive. And a lot of that was allowed because of regulations that were relaxed during the healthcare emergency, right? Because I was allowed to provide healthcare across state lines. I'm licensed to practice medicine in Maryland, but I was able to actually see my patients who travel normally from, neighboring states to come see us. Some of that is no longer possible based on the current regulations, but certainly the telehealth capabilities and our ability to reach people who are not able to get into the health system or maybe don't have access to that level of subspecialty care remains. We've taken steps to incorporate telehealth training for our residents and our frontline healthcare providers to make sure that they know they have this capability. There are differences about a telehealth visit. One thing that's wonderful about it is you can see someone in their home environment where, normally you don't get an opportunity to see the way that someone lives. You get to meet family members, you get to meet pets. I actually had a jam session with one of my patients who had a guitar hanging in the back, and we just decided to play together at the end of our session. So that's a wonderful way to interact with people in their own environment. It does present unique challenges to certain concerns that people may have. Some types of physical exam maneuvers are difficult to do, and that's actually a skill. When do I need to actually say this telehealth visit needs to transition to an in-person visit so I can do the maneuvers or gather the data that I need. So I think that it will continue. There was obviously a concern early on that perhaps people who didn't have access to secure internet connections or devices that would allow them to take advantage of telehealth. Our Society of Bedside Medicine actually funded a study where we looked at Medicare and Medicaid utilization of telehealth visits, and actually there was not a disparity in terms of if you looked at income across different geographic areas. It seemed like there was fairly uniform access to telehealth visits, although the quality of that internet connection, a lot of these visits may have become just telephone visits. So I think telehealth is here to stay. It's obviously not as big of a percentage of our overall visits now as it was at the very beginning of the pandemic, but I do think we need to look at some of these regulations and make sure that we're still being able to provide access, particularly that issue of patients having to travel across state lines. I think we need to take a look at that and see if we can actually expand some of our ability to see patients outside of our geographic or licensed areas.
Thanks, Brian. I'm going to break character as the moderator and take a question because we're getting a few about the significance of the end of the legal public health emergency declaration in the United States. So, first, I guess I should say my qualifications. I am a public health lawyer. I'm not just stepping in for fun. So there are two emergency declarations that our panelists mentioned. The first is the WHO Declaration, Public Health Emergency of International Concern, which will be sunset for COVID. That declaration doesn't have significant legal force. It more puts the world on notice that in a severe infectious disease, in this case pandemic, is ongoing. The second one that we've heard about is the United States declaration at the federal level of a public health emergency. That declaration does have some legal implications, and the reason I'm jumping in now is because Brian was just talking about some of them, including things like what lawyers call licensure portability. So the ability for someone like Brian, who's licensed in the state of Maryland, to provide telemedicine care to someone who's in a jurisdiction where perhaps he's not licensed. And that's a temporary power that's allowed during a declared emergency. There are other implications also with the end of the legal emergency, including changes to certain federally funded insurance programs, including Medicare and Medicaid, that may impact access. So the legal declaration does have important implications. Having said that, and Crystal, I'm going to turn to you in a moment, we also have a question about whether the end of the legal declaration means something in terms of how we think about phases of the pandemic. So because the emergency will end tomorrow officially in the United States, does that mean that we've moved into a different phase of the pandemic? So Crystal, I'll turn that one over to you.
It's a difficult question to answer. I think what it represents is really a broad consensus that we are no longer in an acute emergency phase of the pandemic. I don't think that necessarily means the pandemic is over. As I mentioned, we have not settled into this more seasonal pattern with this virus. And so I think we can't, and no one has declared an end to the pandemic. But it really is an end to this acute emergency where we need to be on guard at every moment and really protect people at the higher levels. So I think that is where we stand.
Thanks, Crystal. Bill, question for you, and this is a topic that I know is you and your colleagues at IVAC spend a whole lot of time on. How can we begin to rebuild trust in public health, but particularly in vaccines?
Mhm. Yes, it's a really important question, and vaccines are kind of one piece of it, and one very important piece of the kind of the mistrust that we've seen in public health institutions, in government, in science in general. Um, I think there are a number of things we can do. We can, one of the key strategies is to work with trusted people, people who are trusted in communities, and these can be primary care providers. These can be religious leaders. These can be political leaders, and really work. We as public health practitioners can work with the messengers within different communities, and first, understand what are the reasons for the lack of trust or the vaccine hesitancy, because that varies by community, and then also, working with these key messengers, these key advocates, to get the message in a way across in a way that folks understand. So it's listening, it's having trusted messengers, it's being flexible and recognizing that one size solution is not going to work everywhere, but also recognizing that that people are at different places on kind of a spectrum of vaccine skepticism or hesitancy. There'll be some people who we can't change their views on, but I think there are a number of a large number of people kind of in the middle on the fence that where we can through those strategies that I mentioned. But this is certainly a problem here in the United States, but we've also seen it's increasingly a global problem, and the pandemic, I think, has really exacerbated that.
Thanks, Bill. Brian, question for you. Can you tell us what masking is like right now in the hospital and clinical settings? How have things changed?
So things have changed fairly recently. So as of 2 weeks ago in our health system, masks are no longer mandatory throughout the health system. There are still certain patient encounters where masking is mandatory based on either risk factors, for example, immunosuppressed patients during a seasonal viral season like influenza and RSV, but also patients who are placed in isolation because they have a respiratory viral illness or other illness that we need to prevent from spreading to other patients. So that slowly has, most hospitals now have gone to masks being recommended but not mandatory. I would say the practice of that is very variable. I still wear a mask when I see patients because oftentimes I'm seeing patients when they're acutely ill and I don't yet know what they have. And so for me, I've still been wearing masks during my patient hours. Obviously, there are benefits to not wearing a mask in terms of being able to communicate. There are certain patients who may be hard of hearing or not able to hear, and they rely on lip reading or facial expressions. So there definitely are reasons why you would consider not wearing a mask for all encounters. But in my practice, since I'm seeing patients with acute illness, oftentimes with respiratory illnesses, and we're waiting testing, I've still been wearing a mask during all of my patient encounters. Mostly not because I'm afraid of getting severe illness from COVID, but also, I don't want to miss work. I don't want to potentially spread a virus to somebody else in the hospital when I'm seeing other patients. So I have not yet gone to not wearing masks, but I would say it's a mixed picture across most health systems right now, but it's no longer mandatory.
Thanks, Brian. Beth, question for you. So in your non-CRC life, you spend a whole lot of time working with cities and local government. Have you seen any spillover effects from all of the data work that's been done during COVID into the day-to-day work of cities relative to data and their data infrastructure?
Yeah, I think we saw a lot of promising practices emerge in local governments throughout the response to COVID. And I think one of the most effective ways that public health organizations in cities and in states were able to use data was to be very targeted about where they were essentially bringing in scarce resources. So in a city like Baltimore, we saw the health department using a very robust data approach to dispatch mobile units for vaccination, for testing, for getting the right kinds of providers into the right communities. And we're seeing that extending now to other areas of public health and also just in service delivery, trying to use data in more robust ways to target scarce resources, to make sure that populations are getting connected into services. I think we've learned a lot from the public health emergency, and a lot of those practices we're hopeful are going to be retained in cities. And that doesn't just stop at the collection of data in a centralized point and the ability of that data kind of guide public policy decision making, but also in the way that we think about how we show up for communities and the way that we think about community engagement. COVID taught us that we couldn't rely on kind of the well-worn paths. Government had to shift into much more community-based solutioning. And so we're seeing a lot of that learning taking hold, and we're seeing that also scale to some of the other areas that we are obviously quite focused on as it relates to improving conditions across a whole host of outcome areas.
Thanks, Beth. Crystal, can you tell us about some of the work that you or your center is involved in to learn as much as possible from the COVID pandemic and also having an eye towards whatever comes next?
Sure. Thanks so much, Lainey. Our center, the Center for Health Security, is working on a range of projects that reflect on our experiences from COVID-19, from looking at community engagement and best practices there to looking at what went wrong broadly in our response and trying to understand where the gaps are and fill them for the future, working on initiatives to look for the next medical countermeasures, to prepare for whatever we might face next from either from a coronavirus or another viral family, and to improve our ability to do risk assessment and make decisions in these public health emergencies so that we can better protect people when we face the next emergency. I think one thing that we're thinking about pretty seriously right now is what we're seeing with avian influenza, H5N1, that's circulating in birds and now spilling over to mammals around the globe. And so I think we will see another pandemic. We hope that it's not in our lifetime, but we've seen this kind of acceleration of the emergence of dangerous viral pathogens in the last few decades. So we need to turn our efforts towards preparing for the next pandemic. And obviously there's a lot to learn from COVID-19.
Thanks, Crystal. Bill, I know that you cannot see the future, but do you anticipate that we're moving into an era where there is an annual combined COVID and flu vaccine? Of course, many of us are now used to getting an annual flu vaccine. Lots of folks wondering, is COVID going that way as well?
Yes, I think that's certainly a likely scenario. You know, as Crystal said earlier, we have not yet seen this virus kind of settle into a regular seasonal pattern. Many experts believe that will happen as many other respiratory viruses do, that it becomes seasonal and in temperate climates, you know, in the winter and early spring. And so it is a little early to say prior to that pattern really emerging. But if SARS-CoV-2 kind of falls into such a seasonal pattern, and we anticipate it will continue to evolve as all viruses do, that, you know, a reasonable strategy would be to have a combined influenza SARS-CoV-2 vaccine that's given annually. As Crystal mentioned, or we've talked about, you know, older adults right now are certainly, and those who are immunocompromised are most vulnerable, so they're going to be the target populations going forward. But I think that's a likely scenario. It's just a little early to say until we see the virus, if the virus will fall into such a seasonal pattern.
Thanks, Bill. Brian, what are the precautions that you're recommending these days for those who are immunocompromised?
Well, I think first and foremost, it's making sure that they're up to date on their current vaccines, not just for COVID, but for other preventable illnesses. While many patients who are immunocompromised don't have the same response to vaccines as someone who's not immunocompromised, there's good evidence that many of them will have some protection from vaccination. So I think that's number one. Number two, we want to make sure that patients who are at high risk of severe disease or death from COVID, which includes patients who are immunocompromised, know about the availability of treatments. Right? We now have available outpatient treatments that we know are effective at preventing severe disease and death. So making sure that patients are aware, hey, if you were to get COVID, this is not just something you want to ride out at home. This is something you want to tell your healthcare provider about right away, and we can get you treated to prevent the likelihood of severe disease and death. And then, I think masks are still effective. So, while there isn't as much COVID circulating now as there was previously at other peaks, there are certain hotspots in the country, and there certainly is still COVID circulating. And so being mindful of your surroundings, being willing to wear a mask and having a good, high quality, well-fitting mask will still be very protective, even in those patients who have already gotten vaccinated. So I think that's an important lesson. And I think we also, all of us need to not judge, this tendency to look around, hey, I'm the only one wearing a mask, maybe I should take it off, right? I mean, that pressure, we need to relax that, right? We can't understand why someone on the subway train or in the theater with us is wearing a mask. We don't understand their circumstances. We don't understand their own health or the health of those around them. And I think we need to just be respectful of those choices that people are making.
Thanks, Brian. Crystal, I want to ask you about a word that's getting thrown around a lot lately, and if you can explain to us what does it mean, and how should we be thinking about it these days? So the word is endemic. I will turn it over to you.
Sure. So endemic really means that a pathogen has settled into a regular pattern where it makes people sick, but it's not typically causing large epidemics. And so I think this is related to the seasonality of the virus that we were just talking about. So we are seeing that COVID is it is still present, as Brian mentioned, but at a much lower level. I think it's still, in my mind, this is still a pandemic kind of cycle, because we are seeing these still relatively to other viruses, big surges of cases, and still seeing hospitalizations and deaths, although the severity has gone down considerably from previous phases of the pandemic. So I don't think we can say that it's endemic yet. At least that's my opinion. I'd be curious to hear what Bill thinks as well. We're still in a pandemic in my mind, and we just have to wait it out and see how this evolves.
Thanks, Crystal. And Bill, please jump in, and Brian and Beth, of course, you are invited to as well. Bill, over to you.
No, I agree. I agree with Crystal, and I think it's important that we, despite the end of the public health emergency that we've talked about, that we recognize this is still a pandemic, and that we recognize, as Crystal outlined in her opening remarks, still an important cause of mortality here in the United States, and we don't want to lose that focus going forward. And as we've said, the pattern of this virus may change, and we may see it settle into a seasonal respiratory disease, much like influenza virus. And as we just said, it will continue to evolve, and we may need a new vaccine as we do with influenza viruses administered annually.
And I think if I can weigh in, Lainey, I think it's important when we first started having these briefings, we talked about how, for many years we had normalized this idea that, influenza happens every year and anywhere from 20 to 50,000 people will die. And that had become sort of something that we accepted. Where we are right now, I think Crystal mentioned this earlier, we're at about 1,000 deaths per week. And if that were to continue, that would lead to, about 50,000 deaths, which is on par with some of the worst flu seasons that we've ever seen that we would be really concerned about. And so, I think it's important while we're talking about how hospitalizations are down and deaths are down and we have good treatments and great vaccines, there still are many people who are dying every week in the and so I don't think we're done with COVID. COVID's certainly not done with us. And so whatever word you use, I think it's important to remember that this is still really impactful and there are still people who are getting sick and dying, albeit thankfully at a much lower level than on our peaks during prior winters.
Thanks, Brian. Bill, question for you. So in the first year of the pandemic, we spent a lot of time, including in these briefings, talking about how it felt like the COVID vaccines, had been developed so quickly. Mm-hmm. Given the existence of that technology for future pandemics, is it likely that vaccines will be developed on such an expedited time frame?
I think so. There are a couple points here. One is, the mRNA technology for vaccine development, and I think as we've spoken before, that there was a lot of work, years and years of work that went into really optimizing that technology before it was used for COVID vaccines. And there was also a lot of work led by Barney Graham at the NIH on RSV vaccines, respiratory syncytial virus vaccines, that provided a foundation for developing a SARS-CoV-2 vaccine with, and the spike protein, against the spike protein. The other thing in a pandemic is that because the number of cases and new infections are so high, you can actually evaluate a new vaccine in a susceptible population rather quickly when you've got a completely susceptible population and a lot of new infections. So there are a lot of things that kind of came together, and that's my main message, a lot of different threads that kind of came together that allowed for the rapid development of the vaccine. I didn't mention, the release of the genetic sequence of the virus in early January by Chinese investigators that allowed the rapid development of these mRNA vaccines. And so I think we are better positioned going forward to rapidly develop new vaccines against certain viral pathogens. And this mRNA technology just has a lot of flexibility in terms of swapping out genetic codes for whether it's new SARS-CoV-2 variants or perhaps other viruses. Crystal mentioned avian influenza viruses. So I think we are better positioned for more rapid development and deployment of new vaccines going forward. I have no doubt there'll be challenges, and vaccine hesitancy is one big one that won't be overcome by technological advances. But I do think we're in a better position.
Thanks, Bill. I'm going to close us out by asking a poll the panelists question. So I'm going to do this in the order that you did your opening remarks. So Crystal, this is going to come to you first. After the last 3 years, are we better prepared for the next pandemic? And in your opinion, what has made us better prepared? Crystal, first to you.
I'm not sure. I think in what Bill just talked about in terms of developing and testing and deploying medical countermeasures, we are probably much better prepared than we were going into COVID-19. But I think we've seen a real degradation of the public health workforce, of our healthcare workforce. I think the trust in government, trust in public health. And so these are things that we need to build back up before we can be prepared to respond to the next event. And it's not insignificant. So there is a lot of investment and rebuilding that we need to do.
Thanks, Crystal. Beth, same question.
I couldn't agree with Crystal more. I think that it's unclear. I think we were caught flat-footed in this pandemic with particularly a focus on data infrastructure. We rapidly were able to scale up at the state and local and even at the national level, but all signals are pointing to the fact that those were not sustained changes, that they were temporary measures, that there aren't a lot of resources or effort going into an actual national in this country data infrastructure. And so whether we'll be caught flat-footed again is certainly an open question. I think that we've learned a lot around data flows and ways that we can improve data collection. And I think the jury's still out as to whether or not those lessons will be heeded.
Thanks, Beth. Bill, same question.
Yes, it's hard to top this, but because I agree, it's mixed. I think we, like I just said, we are better positioned with some of the technological advances, certainly in vaccine technology. But I'll just speak, from the vaccine point of view. Some of this anti-vaccine sentiment, anti-science sentiment has become, I think, more deeply entrenched in many communities, and that's not going to position us well for a next pandemic. And I'll just acknowledge our colleague Tom Inglesby, who leads the Center for Health Security. Just had a piece in the New York Times on how to build back the CDC reputation and build back the CDC better. So there are a lot of things that we need to do to really be better prepared for the next pandemic.
Thanks, Bill. And Brian, you get the last word on this one.
So, I think the real answer to your question is when, right? Because I think our preparedness is probably going to wax and wane. And we saw this in response, when we think about all the money that was invested in 2014, 2015 for Ebola preparedness in the United States. A lot of that money, many people may not realize, a lot of that money went to building regional treatment centers to be able to deal with high consequence pathogens. And here at Hopkins, our biocontainment unit was really on the front lines of getting our health system and our community ready for COVID. But that funding cycle kind of waxes and wanes, and we were sort of at the tail end of that funding cycle from Ebola. And so I think whether or not we maintain preparedness and the what we've gained, the lessons we've learned, really is going to depend on continued funding for public health efforts over the next 5, 10, 15 years. And I think we're already beginning to see, now that the public health emergency is going to be over, is there going to be attention in Congress in particular to fund national preparedness, to fund a national special pathogen system, to fund the ability to develop new vaccines, to fund countermeasure development in anticipation of what may be the next pandemic. The other issue that I think I'm really concerned about that Crystal mentioned is the depletion of the healthcare workforce. During COVID, we've lost so many, particularly nurses, who either retired during the pandemic or after the pandemic because they were burned out from all of the work that they did, or moved on to other positions within healthcare. And so that institutional knowledge and that sort of community that we've built up over many years is exhausted, and we're still in the process of training all the new and excited healthcare professionals who want to continue that work. And so I think we're at risk right now because of how depleted the healthcare workforce is.
Thanks, Brian. I'm going to close us out on that note. I'd like to thank Crystal Watson, Beth Blauer, Bill Moss, and Brian Garibaldi for joining me today. I'd also like to give a big thank you to everyone who attended this briefing, and especially to those who submitted questions for our experts. A recording of this event will be available on this website. Today's panelists, together with many faculty from across Johns Hopkins, continue to conduct research related to COVID and other pressing public health challenges. Thank you again for joining us today, and stay safe.